Okay, so good morning. So I'm Dr. Endyman Irving Tan. So I'll be lecturing the introduction to your neurophysiology, which is your higher center. So with this one, I'll give you a brief concept or a review rather about the functional organization of the nervous system, both anatomical and physiologic. We'll be talking about the different parts of the brain as a bird's eye view, the different function, the integrative function of the brain, the spinal cord, and of course, we'll be discussing some clinical correlation, like if you have a particular disease or manifestation. So, is this on the same side or the opposite side? You should be able to know how to localize because the exams will be quite clinical. And when I repeat some topics over and over again, most likely they would be in the exams. And this would serve as your good concept or fundamental for the succeeding topics in special senses, general senses, and special topics later on before you finish your physiology P. So without further ado, let's start. So for the anatomical functional organization of the nervous system, this is divided into two, the CNS and the PNS. When I talk about the central nervous system, I'm pertaining to the brain and the spinal cord. When I'm talking about the peripheral nervous system, I'm talking about the 12 pairs of cranial nerves and the 31 pairs of spinal nerves. For the 31 pairs of spinal nerves, we have 8 pairs of cervical, 12 pairs of thoracic, 5 pairs of lumbar, 5 pairs of sacral, and 1 coccygeal. So all in all, you have 12 pairs of cranial nerves and 31 pairs of spinal nerves. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. This diagram would show you again the functional organization of the nervous system, mainly the CNS, we have the brain and the spinal cord, and physiologically, the peripheral nervous system is divided into the afferent and the efferent division. When I say afferent division, this is a sensory division. The afferent is a sensory division, while the efferent is a motor division with a motor in function. Again, physiologically, the efferent division is divided into two, the somatic nervous system and the autonomic nervous system. Both of them, we have already learned them in your physiology A. In somatic nervous system, this is a one neuron pathway, meaning to say this is a center, this is a neuron, and the effector organ. So for the somatic nervous system, the effector organ would be your skeletal muscles. For the autonomic nervous system, this is your two neuron pathway. You have your center, preganglionic, ganglion, postganglionic fiber, and the effector organ, a two neuron pathway. And the effector organs for your autonomic nervous system can be the smooth muscles of the GIT, the cardiac muscles of the heart, exocrine glands, endocrine glands, sweat glands, sebaceous glands, erector pili muscles, etc. So autonomic nervous system under involuntary control, okay? So this will be the organization anatomically and physiologically. Now let's talk about the components of the cells, especially in the nervous system. The main cell or the main player is called the neurons or the nerve cells. Neurons or nerve cells. And the helper cells are the neuroglia or the nerve glue or the glial cells. GLIAL, the glial cells or the helper cells or the neuroglia or the nerve glue. So let's focus first on the neurons, the main player or what we call the nerve cells. They are divided into two, the gray matter and the white matter. The gray matter is composed of the dendrites and the cell body or the soma. The dendrites are small, short, branch-like structures that would receive impulses from another axons, okay, of the other neurons, okay? So they are of afferent in function, taga-receive siya. So afferent. And another part of the gray matter is the cell body or the soma, where you can find the important organelles of the cell. Gray matter, you have the dendrites and cell body or soma. The white matter is made up of the axon itself. And the initial part of the axon where the impulse would start or initiate, the initial segment is what we call the axon hillock. Axon hillock. It would terminate into the effector organ, or it can give innervation or give sensory or motor inputs to another dendrites. So the terminal part of the axon is called the terminal arborization or axon terminal, which can innervate either as an effector organ agad-agad, or it can give impulses to another dendrites of another neuron. So gray matter, white matter. What makes the white matter white is because in the axon, or most of the axons, you have this fatty sheath that covers to give protection and insulation. And this fatty sheath is called the myelin sheath. Okay? To give you a review, gray matter is made up of the dendrites and the soma or cell body, while the white matter is made up of the axon. What makes the axon white is because of the presence of myelin sheath. The myelin sheath would give protection and insulation, and it lowers down the resistance for the impulses to be transmitted. Therefore, it increases the speed of impulse transduction. Pinapabilis niya. Because in some myelinated axon, hindi naman buong axon niya may myelin sheath. There are some parts that would lack the myelin sheath. Therefore, the impulses can just jump from one part to another part. And the parts of the axon without myelin sheath is known as your node of Ranvier. Node of Ranvier. And the impulses can jump from one node to another node. And this jumping type of conduction is called saltatory conduction. Saltatory conduction, which hastens the speed of impulse transmission. Gray matter, white matter. So pag paulit-ulit, important siya. In the brain, the gray matter is located outside, while white matter is located inside the brain. Outside is the gray, inside is the white. As compared to the spinal cord, the gray matter is located inside, while the white matter is located outside. So in the brain, gray matter is outside, white matter is inside. In the spinal cord, white matter is outside, gray matter is inside. It is very important. So as you can see, outside of the brain, you have the gray matter because you have the dendrites and the cell body, which gives rise to the axon in the white matter. This now reaches the spinal cord because inside the spinal cord, you have the gray matter with the cell body, and it goes out through the axon in the white matter. Therefore, in the brain, gray matter is outside with the cell body and dendrites. Inside, you have white matter. In the spinal cord, the opposite holds true. Do you understand? This is very important. Clear?
Yes.
Good.
Yes, po.
Okay. Now, let's talk about the different glial cells or the helper cells. You just have to memorize the mnemonic or the acronym SAME, S-A-M-E. You have your Schwann cells, astrocytes, microglia, and your ependymal cells. We'll be talking about each of the different glial cells in the next few slides, but to give an overview, Schwann cells are very important in the production of your myelin sheath. Astrocytes, makikita natin in the next slides as protection, fundamental framework, communication, nutrition. Microglia, para siyang macrophages. Ependymal cells, and in the production of the CSF is very important. Let's discuss them one by one. First glial cell that we'll be talking about will be the astrocytes. The astrocytes are star in shape. Therefore, marami siyang galamay, marami siyang limbs. So first function, they can serve as modulation of communication between cells or among cells, cell-to-cell communication among the different neurons. Second is nutrition. So transport of nutrients from the blood to the neuron, because it has connection with the blood vessel and the neuron, so it can give oxygenation, blood supply to the neurons para mabuhay yung neurons. Thirdly, these astrocytes can give support or framework or skeleton to your myelin coverage. Take note, the astrocytes do not produce the myelin. They only give support or structural framework. Taga-support lang siya to the myelin coverage. Okay, talking about the blood vessel, the blood flow, and oxygenation. In times of crisis, like in an accident, traumatic brain injury, or stroke, there's a deficit or kulang sa blood flow to the brain. There's a lack in the oxygen. So you can have an insult to the brain, you can destroy the neuron. But it would be so expensive to have neuronal damage agad-agad. Because in the presence of stroke, kunwari, a lack of oxygen would increase in the excitatory neurotransmitter agent glutamate, increase in potassium, hyperkalemia. You would have an increase in oxygen-free radicals which can kill your neurons. But hindi si neurons agad yung namamatay. The astrocytes can serve as suicide cells. They can become glial scar or reactive astrocytes. Sila yung unang-unang namamatay. Because yung mga astrocytes na yan, yung mga glial cells, they can differentiate. Pag namatay, gagawa ulit ng bago. So they can form a glial scar or a reactive astrocyte so that the neurons will not be destroyed right away. Next, oligodendrocytes are important because they produce the myelin sheath in the central nervous system, while your Schwann cells would produce the myelin sheath in the peripheral nervous system. So oligodendrocytes, myelin sheath in the CNS, pag peripheral nervous system sa Schwann cells. You have to remember that. What do I mean by CNS 1:many, peripheral nervous system 1:1? If you have an injury to the nervous system, pag central nervous system, mas pangit yung outcome, yung prognosis. You might have a permanent damage na or sequelae. As compared to the peripheral nervous system, the outcome or the prognosis is much better. Why? Because in the central nervous system, one oligodendrocyte would give myelin sheath to many axons. Parang sa classroom, one teacher, 1,000 students. Hindi siya ganun ka-efficient, no? Parang sa central nervous system, one oligodendrocytes would give Schwann cells to many axons. So if there's an injury to one axon, hindi masyadong maganda yung recovery. Most likely, you might have permanent damage na, no? Unlike in the peripheral nervous system, one Schwann cell, one axon. So 1:1, parang nag-tutor, isang teacher, isang student. So very effective siya. So if you have an injury to the axon in the peripheral nervous system, most of the time, the outcome or the prognosis is very, very good. Do you understand? Good. Okay, let's proceed. Now, microglia. Remember our lecture in immunity, the monocytes and the macrophages? The monocytes will enlarge and mature to become macrophages and will just lodge in the tissues. If there is no infection, walang bacteria, walang virus, walang inflammation, the microglia or the macrophages are just there. So in the nervous system, the microglia would serve as macrophages. So in times of crisis, like there's an infection, viral infection, COVID, example, meningitis with the bacteria, fungi, parasites, your microglia would be put into action. They can perform phagocytosis. So microglia are very important to prevent neuronal death by performing phagocytosis. Your ependymal cells are lined by your ciliated, simple cuboidal epithelium. Ciliated, simple cuboidal epithelium. They're very important because they can produce your cerebrospinal fluid. Later on, in the latter part of the discussion, you will see that it is not just the ependymal cells that would produce the CSF. Meron pang iba. But as of the meantime, we just have to remember, ependymal cells are lined by your ciliated, simple cuboidal epithelium that would help in the production of your cerebrospinal fluid, which is very important as a protection for the central nervous system. Now let's move on. Some tumors or cancer or malignancies, okay, of the nervous system, most of them would arise from your glial cells or supporting cells, like your astrocytoma, glioblastoma multiforme, oligodendroglioma, ependymoma, meningioma, schwannoma. And most of these glial cell tumors are very, very aggressive if not treated. Bakit mas common among the glial cells to have tumors or malignancies or cancer? Because those glial cells are said to be not terminally differentiated. They are not post-mitotic cells, meaning to say they can still undergo mitosis. Pwede pa sila mag-differentiate. Some of them can differentiate into cancer or malignant cells. As compared to your neurons, like your neuroblastoma, retinoblastoma, hindi siya ganun ka-common because your neurons are said to be post-mitotic cells. They are post differentiated, they are already terminally differentiated. Meaning to say, they cannot undergo mitosis further. Andun na siya. Terminally differentiated, post-mitotic, so mas rarer siya. Unlike your glial cells, they are not terminally differentiated. They are not post-mitotic cells, so they can undergo changes. And most of them can undergo into malignant change. Are we clear? Very good. They are very, very aggressive and very, very deadly if not treated, or if the patient would not undergo surgery, radiation therapy, or any other treatment course. Now, introduction lang yung kanina. So let's talk about the central nervous system. Again, the CNS is made up of the brain and the spinal cord. But we have some nomenclatures that you have to remember, no? Or understand, rather. Tracts or bundles. These are groups of axons that would carry impulses from one distant site of the central nervous system to another distant site of the central nervous system. Example, from the brain to the spinal cord. From the spinal cord to the brain. Parang long distance flight. From Manila to LA, from Alaska to LA, long distance. Okay, malayuan. Okay, they are their tracts or bundles. How about pathways? Pathways are also group of axons that would carry impulses from one distant site of the central nervous system to another distant site. So tatanungin niyo ko, is ano ng difference ng tracts and pathways kung from one distant site to another distant site? May difference yan. Because for your tracts or bundles, they would carry impulses to another site, distant site, pero they would govern generalized na function. For example, the corticospinal tract would control the motor function of the extremities. Extremities, pwede naman finger, hand, wrist, shoulder, elbow, etc. Hindi specific. Pag pathway, from one distant site to another distant site, pero very specific. Most of the pathways are usually seen in the special senses. Visual pathway from the eye to the brain. Auditory pathway from the ears to the brain. Olfactory pathway, gustatory pathway from the nose, the tongue to the brain. So most likely they are of your special senses. Specific lang yung function. Pwede ka bang may visual pathway from the eyes to the hand or from the brain to the hand ang visual pathway? May mata ka ba sa kamay? Wala. So very specific lang siya pag pathway ang usapan. Are we clear?
Yes, brother.
Good. Let's talk about nucleus, or plural is nuclei, versus ganglion or ganglia, the plural. Nuclei are a group of cell bodies found inside the central nervous system. Pag ganglia, they are a group of cell bodies found outside the central nervous system. So nucleus inside the CNS, ganglion outside the CNS. Okay, let's talk about the spinal cord. Before the spinal cord, there are some things that I want you to remember by heart, and for sure ilalabas sa exam yan. Examples of tracts. I just want you to remember two tracts, the ascending and the descending tracts. When I say ascending, pataas siya, from the spinal cord to the brain, ascending. Dictum number 1. All ascending tracts will have afferent or sensory in function. All ascending tracts, pataas, would have afferent or sensory in function. Dictum number 2, all descending tracts, pababa, from the brain to the spinal cord, would have efferent or motor in function. So pag ascending, afferent or sensory. Pag descending, efferent or motor in function. So of the descending tract, I just want you to remember one as of this point in time. The corticospinal tract. Cortico from the cortex, spinal to the spinal cord. Corticospinal tract. Dictum number 3, almost all lesions or damage to the central nervous system would give you contralateral manifestation, meaning to say opposite side ang manifestation. Take a look. The corticospinal tract, example, the corticospinal tract of the left would start on the left cortex, particularly the Brodmann area 4, Brodmann area 6, which would control the motor movement of the extremities. Okay? So from the left cortex, kunyari lang, no? It would descend down on the same side of the brain up to the level of the medulla, particularly the pyramids of the medulla. So bababa siya on the same side. At the pyramids of the medulla, this corticospinal tract would decussate, would cross over to the opposite side of the pyramid from left to right. So kapag nag-crossover na siya, nag-decussate na siya, it would now go down to the spinal cord, opposite side. So it started on the left cortex. At the level of the medulla, it decussated to the opposite side, going down to the opposite spinal cord. Therefore, a lesion on the corticospinal tract would give you contralateral muscle weakness. So if I'll ask you, a 40-year-old male with stroke affecting the left cortex, which part of the body will have muscle weakness? Same side or opposite side? Very good. It is the opposite side. Contralateral manifestation because this is a central nervous system affection. So almost all lesions will have contralateral manifestations. Are we clear? This is a corticospinal tract decussating at the level of the pyramids of the medulla. Clear?
Yes, po.
Very good. Let's talk about the ascending tract. For the ascending tract, I just want you to remember two. The dorsal column would help in mediating two-point discrimination, vibration, proprioception, etc. But you will learn this in your general senses, so skip. So the next ascending tract that I want you to know would be the spinothalamic tract. Spino from the spinal cord, thalamic, thalamus of the brain. Spinothalamic tract, long distance. Ascending tract. Pag ascending tract, afferent or sensory. For the spinothalamic tract, I want you to remember the lawa, too. You have the lateral spinothalamic tract and then anterior spinothalamic tract. The lateral spinothalamic tract would mediate pain and temperature, while your anterior spinothalamic tract, you remember this one, antopre, anterior spinothalamic tract, touch and pressure, antopre. Touch and pressure for anterior spinothalamic tract. So again, this is a central nervous system problem. So you have contralateral manifestation. Example, the spinothalamic tract, since ascending tract siya, from the right side of the spinal cord, it would start on the right side of the spinal cord. For example, it would ascend. It goes up on the same side until 2 to 3 levels up. It would decussate to the opposite side at the level of the spinal cord. So sa spinal cord pa lang nag-crossover na siya 2 to 3 levels up. So for example, at this part of the spinal cord, right side, it would go up on the same side for 2 to 3 levels. It would cross over to the opposite side, to the left side of the spinal cord. Then it goes up to the thalamus, then to the cortex, spinothalamic tract. And the part of the cortex that controls sensation would be the parietal cortex, the Brodmann area 312, which we'll be learning later. So if I have a lesion in the Brodmann area 312 sa cortex of the right brain, which part of the extremity will I have a problem in my sensation, right or left? Right brain yung may sira sa cortex. Sino yung mayroong sensory deficit? Same side or opposite side?
Same side po.
Ha? It is the opposite side. Why? Because kasi if you trace that spinothalamic tract, maski na sa right side siya kunyari, no? Nag-terminate, pero it goes up same side for 2 to 3 levels, but it crosses over to the opposite side, then it goes up to the opposite brain. So from the right side of the spinal cord, it goes up to the opposite part of the brain. So if the left parietal lobe is affected, which part of the body will you have sensory deficit? Same side or opposite side?
Opposite po.
The opposite side, because this is a central nervous system problem. Okay? Spinothalamic tract. Now, let's talk about the spinal cord. The spinal cord has another dictum, the Bell-Magendie law, that you have to remember. The Bell-Magendie law states that everything posterior or dorsal would have sensory or afferent function. Everything ventral or anterior would have motor or efferent function. Bell-Magendie law. Dorsal or posterior is sensory or afferent. Everything ventral or anterior is efferent or motor in function. And the spinal nerve, is made up of a fusion of the sensory and the motor part, giving rise to the spinal nerve. Therefore, a spinal nerve, which is a part of the peripheral nervous system, is made up of both the afferent and the efferent limbs. Okay? And in the dorsal part, in the afferent part, dorsal, okay, you have this enlargement called the dorsal root ganglion. Remember when you were still younger or children, meron yung chickenpox na tawag, di ba, yung varicella zoster virus infection. So if yung chickenpox mo gumaling na siya, that virus does not usually leave your body. It's just there, okay? Nandun lang siya. Nakatago siya sa dorsal root ganglion. So when you enter adulthood, nagkaroon kayo ng stress, bumagsak immune system, some of you will have shingles o yung mga painful na parbulutong, yung mga vesicular lesions among kung sino mga parents nyo nagkaroon na. Usually those lesions are very painful and they can be located or localized on a particular part of the body. It's because those viruses would reside in the dorsal root ganglion. And the dorsal root ganglion is posterior, so afferent or sensory. So most likely your patients would complain of pain, electrifying pain, para sobrang sakit, sobrang kinukuryente, masakit. And again, everything anterior is efferent or motor in function. Not all segments will have this, what we call the autonomic ganglion. Especially the sympathetic ganglion, they're only found in the C8 and the thoracolumbar areas, okay? So that's the autonomic ganglion. Because yung motor limb, the efferent limb, di ba sabi natin kanina, the efferent division of the peripheral nervous system has both the somatic nervous system and the autonomic nervous system. Pag somatic nervous system, one neuron pathway, effector organ agad. Pag autonomic nervous system, this is a center, preganglionic. The autonomic ganglion is the ganglion, then postganglionic, then to the effector organ. Autonomic nervous system, the autonomic ganglion. Pero hindi lahat ng segments meron autonomic ganglion. Pero all segments would have the dorsal root ganglion. Okay? See, ganglion, they are a group of cell bodies found outside the central nervous system. Are we clear?
Yes, Doc.
Yes po, Doc.
Now, let's talk about the dermatomes. The dermatomes are part of the skin innervated by a particular spinal nerve root. So, peripheral nervous system. Ang dami-daming picture, ang dami-daming nakasulat, medyo nag-overlap, nakakalito, but you just listen to me so I can guide you. Okay? C5, the clavicular area. C5, clavicular area. C6 is the thumb. C7 is the middle finger. C8 is the little finger and medial aspect of the hand. Again, C5 clavicle, C6 is the thumb, C7 is the middle finger, C8 would be the medial aspect of the hand and the little finger. Okay? C5, C6, C7, middle finger, C8 is the little finger and the middle aspect of the hand. T4 is the nipple line. T6 is the xiphoid process. T10 is the umbilicus. T12 is the inguinal area. T4 is nipple line. T6 is xiphoid process. T10 is umbilicus. T12 is the inguinal area. L1, L2, L3 will be the anterior thigh and leg. L4 would be the middle aspect of the foot and the big toe. L5 would be the dorsal aspect of the foot. S1, plantar aspect of the foot. Again, L1, L2, L3, the anterior thigh and leg. L4, the middle aspect of the foot and the big toe. L5 is the dorsal aspect of the foot. S1 is a plantar aspect of the foot. S2, S3, S4 will be your perineum. Therefore, if this is part of the peripheral nervous system, if I have a patient, a 23-year-old male with painful vesicular lesions along the umbilicus area, which dermatomal level is that? Umbilicus.
E10 po.
E10. Would the patient have ipsilateral or contralateral manifestation? Same side or opposite side?
Same side po.
Same side, because this is the peripheral nervous system, the dermatomes. Very good. Now, let's move on to the myotomes. The myotomes are groups of muscles innervated by a specific spinal nerve root. Okay? So, peripheral nervous system. Ang daming muscles. You do not have to memorize this. It's not anatomy class, but I just want you to remember some important myotomes. C5, shoulder abduction. C6, elbow flexion, wrist extension. Elbow flexion, wrist extension. C7, elbow extension, wrist flexion. Elbow extension, wrist flexion. C8, T1 would be the intrinsic muscles of the hand, your interossi, your flexor digitorum, okay? C8, T1. Again, C5, shoulder abduction. C6, elbow flexion and wrist extension. C7, elbow extension, wrist flexion. C8, T1 would be the intrinsic muscles of your hand. L2 would be hip flexion. What is the main muscle for hip flexion?
Psoas major.
Very good, your psoas major. So L2, hip flexion. L3, knee extension, your quadriceps femoris. L4 is ankle dorsiflexion. L5 is big toe dorsiflexion or big toe extension. S1 is your plantar flexion. L2, hip flexion. L3, knee extension. L4, ankle dorsiflexion. What is the main ankle dorsiflexor?
Extensor hallucis longus po.
Ankle dorsiflexion.
Tibialis. Tibialis anterior.
Very good. L5 is your extensor hallucis, so your big toe extension or big toe dorsiflexion. S1 is your ankle plantar flexion. Okay? Very good. Let's talk about the spinal cord. As an overview lang, because you learn more of the spinal cord in the motor system. The spinal cord is important for the somatic and autonomic afferent and efferent pathways, so muscles, voluntary and involuntary in the autonomic nervous system. Center for reflex action, like a myotatic stretch reflex, which we learn in detail in motor system. Example of a myotatic stretch reflex is the patellar reflex. You tap on the patellar tendon, it sends impulses to the spinal cord. Hindi na kailangang isipin pa, automatic sa spinal cord level, meron ka ng reflex action. The reflex arc is completed. Exerts tonic influence on muscles. We have this resting muscle, tonita lupaypay na parang flaccid, because we have the continuous firing, okay? Which is, with the help of the spinal cord, you'll have this resting muscle tone. It is involved in the execution of motor commands. Gusto mo sampalin ng classmate mo, using the spinal cord, magagawa mo yung action. But we have a brain. We have a voluntary will to tell us na lakasan mo para masaktan, or to tell us na wag mong gawin kasi masasaktan siya. So spinal cord, hindi na iniisip, kayang gawin. But we have this voluntary control by the cortex. Center for Micturition and Defecation, tayo nakaupo tayo dito listening to the lecture, delivering the lecture, because in the spinal cord, it will tell us habang nakikinig ka, hindi ka uupo at dudumi at ihi sa upuan. Because the center for the control of the bladder and bowel would be in the spinal cord. That's why some patients with a spinal cord injury, they do not have bladder and bowel control. Dudumi at ihi na lang sila kahit saan. Okay? So let's have a 5-minute break before we proceed to the second part of the lecture, okay? You can eat, you can drink, get something or whatever, okay? I'll see you after 5 minutes. So let's talk about the brain. So when we're talking about the brain, you have to remember the anlage, yung pinaka-parent na kung saan siya nanggaling. So the brain came from the neural tube. And the neural tube would differentiate, no, to become the three primary brain vesicles. So the three primary brain vesicles are your prosencephalon or your forebrain, the mesencephalon or your midbrain, and the rhombencephalon or your hindbrain. So they are your three primary brain vesicles because they will differentiate into the secondary brain vesicles. The forebrain or the presencephalon would become the telencephalon and the diencephalon. The midbrain or the mesencephalon still is the midbrain or mesencephalon. The hindbrain or the rhombencephalon would become the metencephalon and the myelencephalon. Later on, the telencephalons, those secondary brain vesicles, would differentiate again. The telencephalon would give rise to the cerebral cortex and the basal ganglia. The telencephalon would become the basal ganglia and the cerebral cortex. The diencephalon would give rise to your hypothalamus and the thalamus. Diencephalon would become the thalamus and the hypothalamus. The mesencephalon still is the midbrain. The metencephalon would become the pons and the cerebellum. The myelencephalon would become the medulla oblongata. Minsan you will think of it, naku, hirap tandaan, baka magkamali ako sa exam. Sino ba mauna? Mesen, meten, myelen. Alphabetical order. S comes before T, T comes before Y. So S, T, Y. O, diba? So mesencephalon, midbrain, pinakamataas, gitna, pababa. Midbrain, pons and cerebellum, medulla. Mesen, meten, myelencephalon. Now let's talk about the different parts. The medulla, okay, it came from the myelencephalon. You have to remember, the cranial nerves, most of them would have the origins from the brainstem. And the brainstem, yan yung midbrain, pons, and the medulla. The cranial nerves 1 and 2 are said to be the direct invagination of the brain. Cranial nerves 3 and 4 would originate from the midbrain, 5, 6, 7, 8 from the pons, 9, 10, 11, 12 from the medulla. So the medulla, okay, would control your cardiovascular function, respiratory, GIT. Only a few of them would control the auditory vestibular inputs from the cranial nerve 8. Kasi majority, it's the 9, 10, 11, 12. You have to remember, 9, 10, 11, 12 cranial nerves from the medulla. That's why in the medulla, it's very important in the control of your gustatory reflex, the gag reflex, cough reflex, baroreceptor, chemoreceptor, and vomiting reflex. Therefore, in the exams or in clinical scenario, if you have a patient, for example, a 50-year-old patient with a bleed in the medulla, the following functions will be lost. Ano-ano ba yung pwedeng mawalang function? Pupillary light reflex ba pwedeng mawala? Not necessarily, kasi part ba siya ng medulla? Hindi. Pero dapat ano ba yung sure na sure kang mawala sa patient for you to say na medulla ang lesion. The patient will have a problem with 9, 10, 11, 12 the cranial nerve, like loss of gag reflex, loss of cough reflex, loss of cardiomotor tone, vasomotor tone, okay? Bagsak yung blood pressure, respiratory depression, parts of the medulla's function, so you should know how to localize. Another important part of the medulla is the pyramid. What is the clinical importance of the pyramid? This is where the corticospinal tract would cross over or dissociate. For example, from the left cortex, it goes down to the pyramid of the medulla, crosses over to the opposite side before it goes down to the spinal cord. So this is a point where the corticospinal tract would dissociate. So the pyramids of the medulla is very, very important. Next, the pons. The pons came from the metencephalon, and it would have the origins for the cranial nerves 5, 6, 7, 8. The pons. Very important in the control of eye movement. Bakit eye movement? Anyone?
Because of cranial nerve 6 production.
Very good. Cranial nerve 6, which innervates what muscle?
Lateral rectus.
Very good. The lateral rectus. Bakit facial sensation? What cranial nerve is that?
7.
O, facial
5
sensation,
po.
your trigeminal, cranial nerve 5. 7 is the facial expression, taste on the anterior 2/3 of the tongue. How about muscles of mastication? Cranial nerve 5. So you should remember your pons would have the function or the origins of the 5, 6, 7, 8 the cranial nerves. So if your patient will have contralateral loss of muscle tone in the lower quadrant of the face, patient cannot perform yung kissing, patient has weakness, loss of taste on the anterior 2/3 of the tongue. Saan level of the lesion? Midbrain, pons, medulla. Facial expression, wala siyang taste. Midbrain, pons, medulla ang may
Pons
sira.
po, Doc.
Pons. You should know, very good. So you should know how to localize the lesions, okay? Next. Ay, nawala. Oh yeah, it's here. The cerebellum. The cerebellum came from the metencephalon, which is important in the control of coordination, balance, and equilibration. And another dictum is, I told you kanina, almost all lesions in the central nervous system will give you contralateral manifestation, except in the cerebellum. In the cerebellum, you'll have ipsilateral or same-side manifestation. A lesion or a cancer, a stroke in the left cerebellum will give you loss of coordination, loss of balance on the same side, cerebellum. You learn this in motor system. The midbrain, okay, is the highest part of the brainstem and very important in the control of eye movement and pupillary light reflexes. And the midbrain would have the origin of the cranial nerves 3 and 4. Therefore, bakit eye movement? Anong yung mga extraocular muscles innervated by cranial nerve 3? All extraocular muscles are innervated by the cranial nerve 3 except cranial nerve 4, which is blank. Anong muscle?
Superior.
Superior oblique, very good. How about lateral rectus, which cranial nerve?
6 po.
6. Therefore, if you have paralysis of all extraocular muscles, most likely lesion mo na saan? Midbrain, pons, both. Both. Kasi lahat ng extraocular muscles, ibig sabihin cranial nerve 3, cranial nerve 4, cranial nerve 6 na tamaan. So midbrain and the pons. Okay? Another important structure in the midbrain is a grayish part here, grayish black. This is the substantia nigra, which is a very important structure in the production of the neurotransmitter agent called dopamine. Too few of your dopamine will give you a movement disorder called Parkinson's disease. Too much of your dopamine would give you schizophrenia, no? Nababaliw-baliw na yung tao, no? So dopamine, which is secreted by substantia nigra. You learn this again in your motor system. Another important part is the red part here called the red nucleus, or in plural, the red nuclei. In neurology, for example, if you have a patient and you want to assess the Glasgow Coma Scale, or if you want to assess kung mas maganda ba prognosis or hindi, lesions above the red nucleus, okay? Above the red nucleus, mas better ang prognosis because mas shallow yung lesion. So it's just like removing the cortex. So lesions above the red nucleus, we call them the corticate rigidity. The corticate rigidity. Lesions from red nucleus down below, mas pangit. We call them the cerebrate rigidity. It's like removing the entire cerebrum. The cerebrate rigidity. Both of them, syempre pangit yung prognosis, pero mas pangit if it is below the red nucleus, the cerebrate rigidity. Better yung above the red nucleus, which is the corticate rigidity. You learn that in your neurology class. Next, the diencephalon would differentiate into the thalamus and the hypothalamus. And very important, a sensory and motor relay station to the cortex. Example, spinothalamic tract from the spinal cord to the thalamus. And the thalamus would serve as a relay station to send those afferent impulses to the cortex. And the thalamus, hindi na siya pang sensory. The cortex can also send impulse to the thalamus to the spinal cord, corticospinal tract. Okay, so the thalamus. The hypothalamus is very important because of its endocrine control. You've learned in your first few weeks in physiology B, you have your hypothalamus that would secrete your releasing hormones, like your corticotropin releasing hormones, thyrotropin releasing hormones, etc. Endocrine control. The telencephalon becomes the basal ganglia and the cortex. I told you earlier, when I say ganglia, they are a group of cell bodies found outside the central nervous system. This is one exception. The basal ganglia, with the name itself ganglia, they are a group of cell bodies found deep inside the central nervous system, deep inside the gray matter of the brain. Ito yung exception. Yung gray matter na nasa deep inside with the ganglia deep inside. Okay? The basal ganglia. Very important for fine-tuning the movement. Gusto mong sapakin yung classmate mo, the basal ganglia will say na, ito, medyo atras mo konti kamay mo para eksakto sa mukha niya. So in fine-tuning, to making those movements more purposeful, more accurate, okay? The cortex, of course, will help you in memory, learning, cognition, and voluntary movement. I told you earlier, pwede mo sipain ng classmate mo because you have an intact spinal cord, but you will not do it because the cortex would voluntarily tell you not to do it because it is wrong. So meron kang free will from your cortex. And very important is the language. No? Kung wala kang brain, wala kang cortex, wala kang language center, you cannot understand. And language is very important, especially in the dominant hemisphere of the brain. In the dominant hemisphere of the brain, if it is damaged, you can have problems in language. It's a dominant hemisphere. And two types of language disorders that I want you to know will be the Broca's aphasia and the Wernicke's aphasia. Kasi aphasia, no? Broca, B-R-O-C-A. Aphasia ni Broca. So can you ask me one question? You easily nasasagot na question. Not medyo objective. Sige, Stephen Kadukoy, would you like to ask me a question? I'll demonstrate what is a Broca's aphasia.
Any questions po, no?
Any question?
When is Christmas Day?
Yun. When is Christmas Day? May Broca's aphasia ako. Meron akong motor aphasia. Meron akong non-fluent aphasia. Meron akong expressive aphasia. Meaning say, hindi ako fluent. May problem ako sa motor, sa pagsasalita. Broca's aphasia, motor aphasia, non-fluent aphasia, expressive aphasia. So with the question of Stephen, when is Christmas Day? Ang sagot ko is, tama ba sagot ko, Stephen?
Hindi po.
Mali. Kasi hindi nga naman ako sumagot ng tama. But if you give me a piece of paper, I can write there December 25 because I can understand you, pero hindi lang ako fluent, non-fluent, motor, expressive, Broca's aphasia. The other type would be your Wernicke's aphasia, W-E-R-N-I-C-K-E, aphasia ni Wernicke's. Ask me another question, Stephen.
When is Independence Day of the Philippines?
When is the Independence Day of the Philippines? My favorite color is violet. Tama ba sagot ko?
Hindi po.
Mali. Pero fluent ba ako?
Yes po.
Yes. Because I have Wernicke's aphasia. I have sensory aphasia. I have fluent aphasia. Okay? Nakakasalita ako, fluent ako, but I cannot understand you. So mas mahirap, no? Siyempre kung pipili ka, none of the above. Pero kung pagpipiliin ka, Broca's na lang, at least nakakaintindihan pa tayo. Unlike Wernicke's, it's really hard, no? So Wernicke's, your sensory aphasia, your fluent aphasia. Now, let's talk about the protection of the CNS because the brain and the spinal cord are so important that they need to be protected. So we have the bony protection from the calvaria for the brain, and the spinal cord, we have protection from the vertebral column. And the meninges, they are the fibrous sheets of protection of the brain and the spinal cord. From outside to inside, we have the dura mater, arachnoid, and the pia mater. Outside to inside, you have the dura mater, arachnoid, and the pia mater. If you want to get a sample of the cerebrospinal fluid, you have to traverse up to the arachnoid space. So you have to go deep into the subarachnoid space for you to be able to get samples of your cerebrospinal fluid. For example, may bacterial meningitis, you want to check the CSF. So you have to puncture deeper into the subarachnoid space. The cerebrospinal fluid are very important, okay? The CSF is produced by the choroid plexus. Ito yung sasabi ko kanina. The choroid plexus is made up of your pia mater, ependymal cells, and the invaginating capillaries. Diba, I told you that the ependymal cells would be just one of the parts that would produce the CSF, because the choroid plexus is made up of three: the invaginating capillaries, ependymal cells, and the pia mater. So ependymal cells, very important, ciliated simple cuboidal epithelium, helping in the production of the CSF. Bakit invaginating capillaries? Hindi naman dugo ang CSF. Who said it's not? It is said to be an ultrafiltrate of the blood. So whatever component the blood has, meron din si CSF. This one you do not have to memorize. This is not neuroanatomy class, but I just want you to remember na CSF is produced by the choroid plexus, but it has to be reabsorbed by the subarachnoid villi in the subarachnoid cisterns. Why? Because everything in excess, hindi pwede. So yung production of the CSF by the choroid plexus dapat nasa tamang amount lang, and those amount of CSF produced should also be drained properly by the subarachnoid villi. Because too much, it can lead to hydrocephalus din. Too few, walang masyadong cushion yung brain. So mag-umpug-umpugan yung brain. So it can lead to hematoma. Do not have to memorize. I just want to show you that whatever component the blood has, yung CSF meron din. Kung meron siyang potassium, sodium, si CSF meron din. Because the CSF is said to be the ultrafiltrate of the blood. The normal opening pressure of the CSF, no, kapag nag-lumbar tap ka, normal opening pressure is 120 to 100 millimeter water in a recumbent or lying position. 120 to 180 millimeter water in a lying position or the recumbent position. In babies, no, less than 18 months old, if you have too much production of the CSF, o kung hindi siya na-drain out, may barado. Because the fontanelles are not yet fused, your brain can swell, your head can swell up, pwedeng lumaki yung head. But in adulthood, because the fontanelles are already fused, dumikit na siya. So if you have an increase in intracranial pressure because of too much production, may tumor ka pa sa ependymal cells. Or hindi lang siya na-drain out because you have a tumor or something that's blocking the outflow of the CSF. You will have increase in intracranial pressure, more than 180 millimeter water. And since the fontanelles are already fused, the skull cannot expand, your brain will keep on swelling and swelling. The ventricles will enlarge, okay? Mamamaga siya ng mamamaga. After 1 hour, 2 hours without treatment, you'll see your patient will have respiratory depression, loss of vasomotor tone, because the part of the brain na maga ng namaga, hindi naman nag-expand yung skull, it will just go down inside the base of the brain. Doon siya lulusot. It will lead to herniation, leading to death, okay? The blood-brain barrier is again another protection of the central nervous system. In the normal blood vessels anywhere in the body, we have some pores or junction. But in the blood-brain barrier, okay, this in the central nervous system, this is very important because I told you earlier that the astrocytes can have connections between the blood vessels and the neurons. So itong astrocytes, nakabara siya dito, nakakover siya, making the junction of the blood vessels in the central nervous system very, very tight. So bacteria, parasites, virus, or anything cannot just go inside the CNS. Protektado siya. But for example, if you have tumors or you have a breach or nasira yung blood-brain barrier, then yung mga parasites, viruses, fungi, bacteria, anything can go inside, leading to infection. But if those offending organisms are so smart, we as humans, mas matalino tayo. We can give them medications. If you have bacterial meningitis, you treat with antibiotics. Some antibiotics even would have a very good property. It would take advantage of the blood-brain barrier na na-breach, na nasira. Those antibiotics would be very aggressive to penetrate that go inside the CNS to treat the infection. That's why patients with bacterial meningitis, treat naman sila, but you just have to treat them aggressively, and at an early stage, you have to catch them early. Okay? So let's have a 3-minute break before we go to the Wallerian degeneration part. Okay? No, 20 more minutes. So this is the peripheral nervous system. Again, the axon, no? Here is the axon. This is the cell body or the soma and the dendrites and the effector organ. This is the normal. But if there's an injury to the axon, especially in the peripheral nervous system, the distal part of the axon, kung saan siya na-sever up to the effector organ, would undergo Wallerian degeneration. Walley na, no? So the distal part of the axon up to the effector organ would undergo Wallerian degeneration. And the part of the axon where it has been severed will have sprouting. Okay, tutubo siya, uusbong siya. It would regenerate. And the cell body or soma would swell up, increase in size. It will lose its chromatin pigments. It becomes lighter in color, called chromatolysis. And the nucleus would assume a peripheral or eccentric location. So if there's an injury, if the axon is severed, the distal part going to the effector organ would undergo Wallerian degeneration, and the part where it has been severed will have axon sprouting and regeneration. The cell body or soma would undergo chromatolysis because there's a loss of pigment, loss of the chromatin pigments. It would swell up and increase in size, and the nucleus would assume a periphery or peripheral or eccentric location. What do you think will happen to the effector organ? If this is a skeletal muscle, what do you think will happen to the skeletal muscle if nawala na siya ng innervation? Anyone? What would happen to the skeletal muscle if it loses its innervation?
Muscle weakening po.
Muscle weakening because of atrophy, liliit yung muscles, okay? But since if this is the peripheral nervous system, I told you one cell would give myelin sheath to one axon. So this one is having a very good prognosis because the axon can regenerate at the rate of 1 millimeter per day. Medyo matagal, pero at least nag-recover siya, okay? So this one is another diagram of some injuries. So have you tried experiencing lying or resting your head on your arm after 1 hour? Pagising mo, manhid na yung kamay mo with pins and needle sensation. Wala naman naputol na axon or myelin sheath or nerve. It is just you compress lang that myelin, so the transmission of impulses bumagal lang kaya you feel the pins and needle sensation. This is called neuropraxia. This has the best prognosis kasi after a few minutes, okay ka na. You did not cut any axon, you did not cut the nerve, you did not cut the myelin sheath. Naipit lang siya. As compared to axon not misses, axon not misses, axon, you sever the axon, you cut the axon, but the myelin sheath is just there. The whole nerve is there. So yung buong bundle ng nerve, nandun pa siya. It's just one axon lang doon sa loob ng nerve bundle na pinutol mo. So axon not misses. This one is neurotmesis. Imagine, example, the spinal nerve, the radial nerve, pinutol mo. Yung nerve na yan, it contains lots of those bundles of axons inside. So lahat yung pinutol mo. You cut out the nerve, you cut out the axon, you cut out the myelin sheath. So this is neurotmesis. Of course, this is the best prognosis. Gitna, this is the worst prognosis. But still, I told you, if this is the peripheral nervous system, it still regenerates at a rate of 1 millimeter per day. Pero kung ito malaki yung axon na pinutol, malaki yung nerve, mahaba yung nerve, so you just imagine how many years will it take. Pero at least nag-recover pa rin siya unti-unti, no? Let's talk about the brain, the integrative function. The brain is made up of the different lobes. You have 5 lobes, the frontal, parietal, occipital, temporal, and the limbic lobe. Okay? The frontal, parietal, occipital, temporal, and the limbic lobe. So let's try to understand some nomenclatures. Gyri, okay, or singular gyrus, they're the convolutions, yung malukot-lukot dun sa brain. They're the convolutions of the brain. Fissures and sulcus or sulci, they're the fold, yung may mga lines, yung mga folds na yun, mga hiwa na yan, no? But fissures are deeper. Sulcus mas shallow. Example, the central sulcus would differentiate or would separate the frontal lobe from the parietal lobe. Central sulcus separates the frontal lobe from the parietal lobe. Parieto-occipital fissure separates the parietal lobe from the occipital lobe. Parieto-occipital fissure. The lateral fissure would separate the temporal lobe from the parietal lobe from the frontal lobe. Lateral fissure separates the temporal, parietal, and the frontal lobe. So again, this is a picture of the different lobes of the brain. Here would be the Brodmann areas. The Brodmann areas are said to be the cytotectonic architecture of the brain. You do not have to memorize all, baka maloka-loka na kapag memorize na lahat. You just have to memorize some important parts or the Brodmann areas that I'll be telling you. So first, you should know where is the central sulcus, because everything anterior to the central sulcus, frontal lobe. So central sulcus, immediately anterior is a Brodmann area for primary motor cortex or the precentral gyrus. So Brodmann area 4, immediately anterior to the central sulcus, is the precentral gyrus, or the primary motor area, or the primary motor cortex, Brodmann area 4. This would give you voluntary control of your muscle. Okay, pwede gusto mo sipain yan, the Brodmann area 4 will let you do it. But the Brodmann area 6, which is immediately anterior to Brodmann area 4, is a motor association cortex, the premotor area. The premotor cortex, premotor. Reason before you do it, you will plan it out. You have to plan it. Kung tama ba to, lalakasan mo ba, hihinaan mo. This is a premotor area or the premotor cortex or the motor association area. Brodmann 6. Brodmann 8. 8 is like a binocular. This is for your frontal eye field. Frontal eye field. You learn this in your vision. Another important Brodmann area in the frontal lobe is the 43. 43 is the inferior frontal gyrus. Inferior frontal gyrus. This is for your gustation and olfaction, taste and smell. 44, especially in the dominant hemisphere of the brain, is the Broca's area. Now you already know what is the function of the Broca's area. Okay, Broca's area for language. Broca's area, 44. Central sulcus, immediately posterior is the nasa parietal lobe ka na. Immediately posterior to the central sulcus is the Brodmann areas 312. 312, also known as the post-central gyrus. Post-central gyrus, or the primary somesthetic cortex. Primary somesthetic cortex for sensation. So since this is the central nervous system, a lesion on the right Brodmann area 312 will give you loss of sensation on the same side ng extremity or opposite side.
Opposite side po.
Opposite side, very good. Kasi central nervous system. Brodmann area 312, primary somesthetic cortex, post-central gyrus. Let's go to the occipital lobe. The Brodmann area 17, 18, 19, they belong to the calcarine fissure. Calcarine fissure, very important for vision, because Brodmann area 17 is your primary visual cortex. 18 and 19 will be your secondary visual cortex or your visual association cortex. If you have a destruction or a lesion in Brodmann area 17, you have blindness. 18 and 19, pag nasira, intact si 17, you can see but you do not know kung ano yung nakikita mo. Brodmann area 39, some textbook would say 22, so to avoid confusion, we just call them the Wernicke's area. A lesion to that will give you Wernicke's aphasia, okay? And the temporal lobe is very important for the hearing, okay? Audition, which you learn in the specific topic soon. Let's talk about language again. And aphasia, you've already learned the Broca's and the Wernicke's aphasia, the dominant hemisphere. Pag non-dominant hemisphere ang nasira, you'll have cortical neglect. So if I'll ask Dr. Fargas Louis, okay, Fargas, Louis, can you please eat the food on the plate? Kakainin lang na isang side lang. The other side is still there. If I'll ask him to comb his hair, yung isang side lang gagawin niya. Because there is cortical neglect. If I ask him to draw the face of a clock, isang side lang din draw niya. Yung kalahating clock, face ng clock, hindi niya i-draw. Because there's cortical neglect, a lesion in the non-dominant hemisphere of the brain. When I say graphesthesia, you should be able to identify what is the written letter or number on your body part with your eyes closed. So if I'll ask Dr. Fargas to close his eyes, and I'll write on his right palm the letter A. Just sabihin niya sa akin, letter B. Ano yung may sira dyan? So it is your primary sympathetic cortex, your parietal lobe ang may problem. Why? Because the parietal lobe is the area that governs general sensation. So saan yung may sira? Kung sa right hand ako nagsulat, which parietal lobe kaya yung may sira? Is it the right or the left? Same side or opposite?
Opposite.
Opposite, because this is a CNS lesion. Astereognosis, failure to identify some familiar objects by touching with your eyes closed. So if I ask Nicole, close your eyes, touch mo nga to, so cellphone to. Tapos pag sabihin niya, ay, this is a ball pen, mali. Because the patient might have astereognosis, a problem with the parietal lobe, particularly the Brodmann area 312. Okay? Now, let's talk about hand dominance. Most of us, di ba, right-handed tayo. And 96% of right-handed people would have the left brain as the dominant hemisphere. Only 15% of left-handed people would have the right brain dominant. 15% of left-handed people would have no clear lateralization, pwedeng right, pwedeng left. 70% of left-handed people would have the left brain as the dominant hemisphere. So this tells us that almost all of us, either regardless of right-handed or left-handed, still it is the left brain dominant. Okay, are we clear on that? Most of the population still left brain dominant. So in a right-handed person, it is said that the left brain is the dominant hemisphere for logical or mathematics, analysis, computational. Ako parang ayoko na yata maging left brain dominant. Gusto ko lang mag-compute ng grade. Sequential, you do things one step at a time. Factual, makatotohanan, academic, and function. Right brain dominant, sila daw yung imagination, synthetic, intuition, holistic. You do all things at the same time. Haka-haka, no? Imagination. Uses imagination, colors, and music appreciation, emotion. So sige nga, Nicole, you try to ask me a question. Yung kung anong color ni ganyan or whatever. So I'll tell you the difference between the right and the left brain dominant. Sige, Nicole, any question?
Doc,
Yeah. Yeah. Naka-silent yung, naka-off mic mo.
ano po, Doc? Anong color po ng sky?
Oh, anong color ng sky? Blue. So left brain dominant ako, no? Blue ang sky. Kasi yun na yun. Factual, yun na yun. But if you'll ask me the same question, if I'm a right-brainer, I'll tell you it is robin egg blue with a tinge of turquoise. Alam mo yun, I use my imagination, I use yung my art appreciation. You get the point? So I think some painters, actors, musicians, they are more of a right-brainer. Pero syempre maganda pa rin yung na-balance, no? So this one will tell you here in the left visual field, the rabbit is in the left visual field. Kung nakikita mo siya sa brain, projected to the right side. So this is projection of image. You learn these things in vision of physiology. So this tells us that the left brain, very important for factual, mathematics, computation. But the right brain is for music appreciation, art appreciation, color appreciation, okay? So I think this is the last slide about brain dominance. So we have tackled the functional organization, anatomic, physiologic. we've discussed how to localize lesions, part of the brain, function, language, dominance, and this would serve as your framework or background for your neurophysiology, because after neurophysiology, after the midterms, a few topics in finals, you'll reach your special topics, which means malapit na kayo graduate ng first year physiology B, which is second year na kayo. So if you do not have any questions, I wish you all the best, good luck in the exams, and see you around.